Morning, everybody. Good morning, Nimeshji.
Very good morning, sir.
Good morning. Good morning. So, Sahib, you are ready? Sahibsingh.
Good morning, sir.
Dr. Jaiswal is there.
Yes, sir. Good morning, sir.
Good morning, Sanjeev. How are you?
Fine, sir.
Good to see you. And so your image is not clear, Sahib. Can you put on the lights also, the seminar room? And I just
Yes, sir. Yes, sir.
the seminar room also.
Yes.
Yes, that's better.
Now it is clear.
That's better. And put the light. Put on the seminar room video also.
रिफ्लेक्ट करेगा आपके सामने ऐसे लाइट जलाओ इससे रिफ्लेक्शन कम आए स्क्रीन पे ये ट्यूबलाइट ये शायद आ रही है
Nimeshji, just let me know when it is exactly 8:30.
Sure, sir.
Right. So today we have Dr. Sahibsingh who is going to present, and Dr. Sanjeev Jaiswal would be the moderator. Right. We do not have any. We will have expert faculty. If we find anybody joining from outside, we'll keep them as expert faculty. So, Sahibsingh, restrict your whole thing into 20-25 minutes, 25 minutes maximum.
Yes, sir.
Actually, there was a little time to improve upon the topic and the presentation that you had sent me, because what we meant was more on chronic prostatitis rather than general chronic pelvic pain syndrome, which could be a kind of a very diverse topic. But anyway, whatever you have presented, we will just try to.
Sir, good morning.
Good morning, Nachiket. How are you?
मैं ठीक हूँ sir.
Great.
Good morning, sir.
So today is a special. Today is rather a kind of a sad day because we have lost one of our very prominent urologists, one of the probably father of urology, one of the great mentors in urology, Dr. Roy Kelly. So once we start, we will just keep maybe half a minute silence for that. And another, today is an important day in the sense today is the birth anniversary of a great genius. Who was it? Albert Einstein. Today is the birth anniversary of Albert Einstein.
Sir, should we start?
Right, please go ahead.
3, 2, 1.
Very good morning to all of you. Once again, welcome to the teaching session of Department of Urology, Savai Mansiddh Medical College, Jaipur. So before we start today's teaching session, I would like to announce, and probably all of you must be knowing, that today is a sad day for urology, as we have lost a great urologist, a great mentor, Dr. Roy Kelly. Dr. Roy Kelly was, I think, one of the fathers of urology, you can say, and great mentor, a very gentleman to the core, great gentleman, and he was a great academician, definitely. I have come across or personally met him many times, and he also visited our department, and he used to come for the DNB exams when it started in 1990s, when Dr. S. C. Mathur was there. So along with Dr. Sashidharan, and so we'll keep half a minute silence, and then start our teaching session. Thank you, everybody. So now we'll start the session. Today, session is on chronic pelvic pain syndrome, and it will be presented by Dr. Sahibsingh and moderated by our faculty, Dr. Sanjeev Jaiswal. So Dr. Sanjeev Jaiswal, please take over and invite the presenter.
Good morning, respected seniors and colleagues. I welcome you all. I would request to Dr. Sahibsingh to share his presentation. Dr. Sahibsingh, please.
Yes, sir.
Go ahead.
Good morning, respected Shivam sir and respected faculty and seniors and my dear colleagues. I'm here to present a topic, chronic pelvic pain syndrome. My moderator is Dr. Sanjeev Jaiswal sir.
Please make it full screen.
So it is full, sir.
Anybody in the hall, can he be helped by anybody?
Yes.
Yes, thank you.
Slide is visible, sir.
Yes, go ahead.
Yes, sir. The chronic prostatitis or chronic pelvic pain syndrome, which can be defined as by the NIH, as per NIH, symptom of the pain or discomfort in the pelvis for at least 3 of previous 6 months, along with several exclusion criteria also included, like urogenital cancer, prior radiation or chemotherapy, or urethral stricture or neurologic diseases affecting the bladder. The pain was thought to come from the prostate, from the infection or from the inflammation. However, we now recognize that the prostate may not be the source of the pelvic pain, and the term chronic pelvic pain syndrome was adopted to reflect this understanding. The term chronic pelvic pain syndrome is also called category 3rd prostatitis, as described in NIH classification of the chronic prostatitis, which was published in 1999. As per NIH classification, prostatitis categorized into 4 categories. In category 1, known as acute bacterial prostatitis, which is characterized by the acute infection of the acute inflammation of the prostate gland. In category 2nd, known as chronic bacterial prostatitis, which is characterized by recurrent infection of the prostate of the same organism. In category 3rd, the known as chronic pelvic pain syndrome, which is non-bacterial or showing no positive organism. It can be of 2 types. One is inflammatory or non-inflammatory, based on WBC in expressed prostate secretions. In inflammatory type, there is a WBC in the there is a WBC in expressed prostatic secretion, and in non-inflammatory type, no WBC in the expressed prostatic secretion. The 4th category is asymptomatic inflammatory prostatitis. This entity is incidental in diagnosis, and the inflammation shown either by the prostate biopsy or presence of the WBC in expressed prostatic secretion during the evaluation of the other disorder like infertility or prostatic cancer. The prostatodynia the chronic pelvic pain syndrome has also been termed as prostatodynia. The use of this term is not encouraged in correct practice because the source of the patient's symptom invariably lies within the prostate gland itself. What we understand before, but the current research has provided the evidence of the numerous extraprostatic considerations, including neuropathic and other systemic pathologies. The histopathology of the prostatitis, the recommended reporting information in prostatitis by the anatomic location in the prostate, either glandular, periglandular, or stromal. The extent of the information is defined as focal, multifocal, or diffuse. Focal, less than 10% involvement, or multifocal, 10 to 50%, and diffuse when involved, greater than 50%. The prostatitis grade 1, 2, or 3. In grade 1, if the individual inflammatory cell separated by the distinct species or number of cells less than 100. Grade 2, if the confluence seat of the cells with no tissue destruction or lymphoid follicle, and number of cells 100 to 300 cells. In grade 3, or severe if the confluence seat of the inflammatory cells with tissue destruction or nodule formation, and number of cells is 300 to 500. In epidemiology, the chronic pelvic pain syndrome account 90% of the cases among all the prostatitis. The prevalence of the symptom in the women, it is 5 to 7%. In men, it is 2.7%. Overall prevalence in Asia is 2.7 to 8.7%. The chronic, it affects the pain of the any age. Median age of the incidence is 43 years. In etiology, the cause is unknown. The cause is unknown. The several theory of the possession are there. The evidence to support a possible role for the infection, possible role of the infection, neurologic causes, inflammatory, autoimmune, endocrine, and psychological factors. It is likely that the interplay between all these above factors to contribute a creation and continuation of the pelvic pain. In etiology, the insulting factor like infection, immunogens, toxin, trauma, and stress. And with this, the body response is inflammation or inflammatory neurologic injury, which facilitated and propagated by the immunologic, neurogenic, endocrine, and autoimmune. And the final outcome is neuropathic pain. In clinical presentation, the traditional presentation of the chronic pelvic pain syndrome is pelvic or perineal pain associated with the voiding or sexual dysfunction, which is characterized by the inconsistent, relapsing, or remitting force. There are 4 symptom categories: perineal or pelvic pain associated with the voiding symptoms, sexual dysfunction, or systemic conditions. In pelvic pain, the primary and most common symptom in chronic pelvic pain syndrome is pain. Most common site is perineal region or genital region, but can also present such in other sites such as suprapubic area, penis, scrotum, or testes, and rectum, and lower back. The pain also patient also manifests with the pain during the voiding, pain during or after the ejaculation. This pain, the onset of this pain is usually sudden. The intensity of the pain can be mild, moderate, or severe. A 30% patient had a mild pain, 52% patient had a moderate pain, and 16% patient had severe pain. Other than pain, the urinary symptom, which can be obstructive or irritable routes, both are common. Other than this, ejaculatory problems, the pain during or after the ejaculation, it can be premature or delayed ejaculation. Systemic symptoms, patient can present with myalgia, arthalgia, or unexplained fatigue, or bowel symptom, irritable bowel symptom or syndrome. Patient may have the anxiety, depression, or cardiovascular diseases. The phenotypic approach to the symptom clustering, which is outlined as a U-point classification. It has 6 dominant: urinary, psychological, organ-specific, infection, neurologic, and tenderness of the pelvic muscles. A recent clustered analysis of the men with the chronic pelvic pain syndrome demonstrated 2 clusters: pelvic group or systemic group. Pelvic group, urinary, organ-specific, or tenderness of the muscle, and systemic group, neurologic, infection, and psychological. This classification is developed by Sox et al. In part of the recognition of the failure of monotherapy for the chronic pelvic pain syndrome. It helped in directing the evaluation and subsequent therapy of the pelvic pain syndrome. The U point is then U for the urinary, P for the psychosocial, O for the organ specific like bladder and prostate, I for the infection, and N for the neurologic, and T for the tenderness of the pelvic floor muscles. The snowflake hypothesis, in a snowflake hypothesis, just like a flake of the snow, which is not same and unique and different to each other. In a similar way, the patient of the chronic pelvic pain syndrome manifest different. They are unique in their phenotypes. Evaluation. In an evaluation of the chronic pelvic pain syndrome, the evaluation must rule out the identifiable causes of the pelvic pain as it is diagnosis of the exclusion. So, following are the evaluation tools, which can be some of them are mandatory, are recommended, some of them are recommended, or some of them not recommended. In mandatory, the history, physical examination, and urine routine microscopy and culture. In a recommended, evaluation tool are symptom inventory, like use of the NIH, like National Institute of Hospital, CPSI, like chronic prostate severity index, or GUPI, like genitourinary prostate index, and sexual function. Second is sexual function assessment, or urine 2-glass test, or urine flow rate, or urine cytology for the dysuria or hematuria in search of the carcinoma institute of the bladder. Other are bladder ultrasound for the post-void residual urine in search of the bladder outlet obstruction can be a cause of the pelvic pain syndrome. Not recommended for the initial evaluation in the all patient, but they are optional in selected patient. Like urine nuclear amplification test for the STDs. Some are imaging studies like scrotal ultrasonography used for the testicular pain, or transrectal ultrasound used for the to look for the seminal vesicle or ejaculatory duct, or CT of the abdomen for the abdominal pain, and MRI of the lumbosacral spine for the symptom that's suggestive of the disc hernia, it can be a cause of pain, and urodynamics and cystoscopy for the indicated for the refractory roots, and PSA indicate for the in search of prostate cancer screening. Now, history. The history of the pain, which is assessed with the NIH CPSI score or GUPI score. The CPSI score include pain severity, location, frequency, and voiding and quality of the life, and GUPI score include, in addition of the above, bladder filling and bladder emptying. In this way, we can assess the pain. History of the voiding assessed by the IPSS score and AUS symptom index score, like obstructive and storage symptoms. The history of the ejaculatory pain or premature ejaculation, rectal dysfunction, libido, history of the chronic UTI or STD, history of the trauma for the neurologic damage or musculoskeletal abnormalities, history of the back pain or numbness of pain radiating down to the leg, which is the lumbosacral risk diseases, for evaluated for the concomitant neurologic diseases, like history of the bowel symptom like constipation, diarrhea, relation of the discomfort to the bowel movements, because this IBS, inflammatory bowel syndrome, is associated with the chronic pelvic pain syndrome because the overlapping innervation of the bowel and bladder. History of the generalized fatigueness, which is not explained in search of the fibromyalgia and chronic fatigue syndrome, and history of the anxiety, depression, obsessive compulsive disorder, panic attack, psychological trauma, pelvic floor dysfunction. On physical examination, first the abdominal examiner to look for other causes like abdominal and suprapubic pain, and examination of the penis, scrotum, perineum, prostate, inguinal area for the to look for the hernia, hydrocele, testicular masses, and penile lesion, which would be cause of the pain. On rectal examination, the prostate is standard in 22% of the cases, but most of the patient, on DRE, the prostate will be normal. In pelvic muscle examination to look for the pelvic floor tenderness, the pelvic floor muscles were palpated through the rectum. In this picture, we can see one is posterior, anterior, and anus and prostate. We put a finger into the rectum through the anus and palpate the posterior aspect of the rectum, or lateral aspect of the rectum, and anterior aspect of the rectum. When we palpate anteriorly at the prostate apex, we can palpate the urogenital diaphragm, or laterally obturator muscle, and posteriorly levator ani muscle. The differential diagnosis, the following are the conditions that can mimic the chronic pelvic pain syndrome. These are granulomatous prostatitis, various abscess and cysts, prostatic infections, benign prostatic hyperplasia, fistulae from the adjacent organ, prostatic urethral brachocele, some minor vasculitis, bladder prostatocalculi, urethral tumor of the prostate, UTI, interstitial cystitis, overactive bladder, radiation cystitis, bladder cancer, urethral diverticulum, bacterial urethritis, and diabetic mellitus, pudendal nerve entrapment, and chronic scrotal pain syndrome. One of the differential diagnoses is interstitial cystitis and bladder pain syndrome. These both entities are same in their pain, urinary symptoms, diet, diagnosis, and potassium sensitivity in the bladder, and treatment. The both entities are not mutually exclusive condition, as they have much in the common with their respect to their pathogenesis and clinical presentation, as shown in our table. Based on the working definition of these terms, it would be correct to say that the male bladder pain syndrome is included under the chronic pelvic pain syndrome. The male bladder pain syndrome may be regarded as chronic pelvic pain syndrome with clear bladder specific features. In treatment, as we know, the etiology is multifactorial, so we have multiple treatment options. First is pharmacologic treatment, then in pharmacologic treatment, antibiotic, alpha blockers, anti-inflammatory drugs, medication for the neuropathic pain, and phytotherapy or pentosan polysulfate and PD5 inhibitors. In antibiotics, the recommended antibiotic for the chronic pelvic pain syndrome is quinolone and tetracycline, which can give over a minimum of 6 weeks in treatment patients. The repeated course of the antibiotic in the absence of the positive urine culture are not indicated. In an alpha blocker, the alpha blocker are likely ineffective when we give alone, but useful in combination with antibiotic or with anti-inflammatory medication. In anti-inflammatory drugs, likely ineffective if used alone, but useful in combination with the alpha blocker or muscle relaxant. In 5-alpha reductase inhibitor may be best used in older patients with chronic pelvic pain syndrome who also have voiding symptom. Medication for the neuropathic pain, pregabalin, which is used in some patients, which is effective in some patients, and duloxetine has shown in beneficial effect of when combined with the tamsulosin or saw-palmetto or with alpha blocker doxorubicin. Amitriptyline has been widely used in the women with the interstitial cystitis, but data in the chronic pelvic pain syndrome are lacking. In a phytotherapy, Sernilton, a pollen extract, which is given for the 12 week, and quercetin, a plant-derived bioflavonoid, which has showed a significant improvement in symptom when we give 4 weeks. The pentosan polysulfate of PPS, this is bladder-specific therapy, has shown modest improvement compared with the placebo. It is recommended by the European Association of Urology guideline, but with a strength rating of peak. The PD5 inhibitor tadalafil are useful to treat erectile dysfunction in men with chronic pelvic pain syndrome at any age. After the pharmacologic treatment, the non-pharmacologic treatment options, the lifestyle changes with the diet or exercise, stress management or psychological treatment, acupuncture, pelvic floor physical therapy, and adjunct to the pelvic floor therapy, there are perineal injection of the botulinum toxin or extracorporeal software therapy, the prostate massage or circumcision. The prostate-specific treatment options are transrectal radiofrequency or microwave and intraprostatic injection of the botulinum toxin A. In a surgical therapy options, transurethral resection of the prostate and sacral nerve stimulation, percutaneous tibial nerve stimulation, and electromagnetic stimulation, and cystoscopy and fulguration of the Hunner ulcer if they present in the cystoscopy. A radical prostatectomy, this is not recommended. In a 2000 Cochrane review of the non-pharmacological intervention, which I described in previous slides, the conclusion was that the sum of the intervention can decrease prostatitis symptoms in an appreciable number, but quality evidence was mostly low. So they encouraged the future clinical trial and requiring further evaluation for the non-pharmacological interventions. These are the recommended. The following treatment options are recommended, like alpha blocker therapy as a part of multimodal treatment strategy for the newly diagnosed or alpha blocker naive patient who have voiding symptom. Second, antimicrobial therapy trial for the selectively newly diagnosed antimicrobial naive patient. Selected therapies are phytotherapies are recommended, and multimodal therapy directed by the clinical phenotypes are recommended, and directed physiotherapy, although the level of the evidence is not available and evidence for the multiple peak trial and vast clinical experience strongly suggests the benefit for selected patients. And following therapy are not recommended, like alpha blocker monotherapy, anti-inflammatory monotherapy, antimicrobial therapy monotherapy, and 5 alpha reductase inhibitor monotherapy, and most minimal invasive therapy like transurethral needle ablation or laser therapy are not recommended, and invasive surgical therapy like transurethral dissection of the prostate and radical prostatectomy are not recommended. The following treatment options requiring the further evaluation, like low intensity shock wave treatment, acupuncture, biofeedback, invasive neuromodulation, electromagnetic stimulation, botulinum toxin injection, and medical therapy like nepartricin or muscle relaxant neuromodulators and immunomodulators. The treatment approach for the chronic pelvic pain syndrome, the treatment is best undertaken as simultaneous multimodal therapy, which addressing all the patient symptoms. DuPont classification is recommended in the current guideline for the treatment by the European Association of the Urology, and offer a convenient framework in which to plan the treatment, which is showing in the next slide. If we suspect the chronic pelvic pain syndrome and evaluate to place the patient in a particular clinical domain. For example, like urinary like voiding storage. If the patient present with the voiding or storage symptom, we can give alpha blocker, anticholinergics. If the patient has depression or anxiety, we can give the cognitive behavioral therapy or antidepressant medication, anxiolytic drugs. If the patient belongs to a clinical domain like organ specific, it may be prostate or bladder. If we found prostate tenderness or inflamed prostate, we can give Sanelton or quercetin, anti-inflammatory drugs we can give, or bladder. If we found the bladder pain syndrome like improvement of the pain with voiding or worsening of the pain on the filling of the bladder. Then we can give the PPS, pentosan, polysulfate, quercetin, or intravesical therapy. If the patient have a positive culture in urine, or if we respond with the antibiotic, then we can give further antibiotics like neuropathic pain. If we found a neuropathic pain, we can give the gabapentin, amitriptyline, neuromodulation acupuncture. If on physical examination, if we found the tenderness of the pelvic floor muscles, then we can give the physical therapy by feedback, extracorporeal software therapy, exercise and heat therapy. If we found the ejaculatory dysfunction or erectile dysfunction, so we can give the PD5 inhibitor like tadalafil. Apart from that, we have a step care approach. In this first step, if we diagnose the patient like chronic pelvic pain syndrome, we can give as the first step antibiotic for 6 to 12 weeks with alpha blockers. Antibiotics 6 to 12 weeks with alpha blockers for 12 weeks if the voiding symptoms are there, or with anti-inflammatory drugs for the more than 6 weeks if the pain is a dominant complaint. If after that, if the symptom persists, then we can go for physiotherapy for more than 6 months. If the patient have bladder specific bladder pain syndrome or bladder specific symptoms, we can give the pentosan polysulfate greater than 6 months. If the patient is older age and avoiding symptom, we can give finasteride for more than 6 months. If still the pain is persist or symptom persist, we should give gabapentin, amitriptyline, neuromodulation, and acupuncture. Thank you.
Thank you, Sahibsingh. Dr. Sanjeev, any comments? And please go ahead.
CPP is difficult to treat, sir, but
Louder, please.
I welcome to expert
Yes.
faculty to share his experience about CPP, sir.
Okay. So any of the faculty members would like to give any comment?
Sir, Neeraj here, sir.
Neeraj, go ahead, please.
A nice presentation, Sahib. I think you covered all the topics in that prescribed time of yours. CPPS definitely, it's both a difficult problem to diagnose firstly and then to treat. And most of the times CPPS is often, confused with other disorders of both GI and urinary systems like interstitial cystitis, irritable bowel syndrome, proctalgia fugax. All these conditions can mimic the symptoms of CPPS. Could you just tell me whether CPPS, if chronic bacterial prostatitis, would be included under the domain of CPPS, Sahib?
No, sir. The CPPS non-bacterial prostatitis. Sir, the chronic pelvic pain syndrome is a non-bacterial prostatitis. So we do not include in chronic bacterial prostatitis, sir.
Then in the management part, why have you, said that antibiotics should be given if the cultures are positive? If antibiotics are to be given, then it is not CPPS.
Right, sir. Because, sir, the organism in chronic pelvic pain syndrome, the organism are concentrated in the pelvis, but they are not come in the urine culture. So they can be.
Sahib, Dr. Neeraj is correct in the sense that it is a chronic non-bacterial prostatitis, and often you do not require a course of antibiotics in these patients, and you would often treat them with the other therapies. So the step care approach that you have shown is probably not correct, because you cannot generalize the treatment of chronic pelvic pain syndrome. You have to find out, as you said, in phenotyping. The U-point phenotype is more kind of a good approach. for the treatment of chronic pelvic pain syndrome, where you find out exactly which is the more dominant factor, whether this is urinary, psychological, it is pain, or it is bladder related, interstitial cystitis, or so. So you need to find out exactly the source of pain and try to treat that according to the phenotype. So it's not good to have a generalized treatment approach or a step care approach, giving the blanket treatment to all patients. Anything else? So today, Dr. Nachiket, if you have anything to say, please go ahead. Otherwise, we'll wrap up the session. So chronic pelvic pain syndrome is more often is a chronic non-bacterial prostatitis, and it may have some kind of symptoms which mimic chronic scrotal pain or chronic orcalgia, or Dr. Neeraj said about the proctalgia. So all these symptoms can be confused with chronic pelvic pain syndrome in males, whereas in females, it is could be vestibular dynia. Vestibular dynia is a very important cause of pain in females. Then it could be endometriosis of the pelvis, and definitely bladder pain syndrome or interstitial cystitis. We nowadays have seen that though interstitial cystitis was considered as more of a female problem, it is more often nowadays being seen in males also. So we have seen many patients of interstitial cystitis in males. So it is no more a disease of female only. So it is more commonly now found in males also. So chronic pelvic pain syndrome is actually a multifactorial etiology, and where the pain may originate from urogynecological system, GI system, from pelvic floor, musculoskeletal muscles, and even nervous system. So what happens, there is a crosstalk between the organs, and this crosstalk will result in sensitization. First, it causes a peripheral sensitization and then a central sensitization of pain. So that is why this pain becomes very chronic, and it's very difficult to treat these chronic pains because of this central sensitization. And the symptoms also can result from an interplay between various psychological and other organic reasons, which can arise from immune system, nervous system, and even endocrine system. And so therapy should also has to be a multidisciplinary approach, and it requires a multiple doctors, a team of doctors to treat this particular patient. It's a very chronic disease. The patient loses a lot of quality of life, and so it is very important that we treat them holistically with a multidisciplinary approach. So thank you very much. Please give a vote of thanks, Dr. Sanjeev Jaiswal, and then we will wrap up the session.
Thank you all for your sharing time with us. Thank you.
Thank you. Thank you very much. Thanks all the faculty members and residents. Have a good day.
Thank you, sir.